Okay, ma'am. We are live now.
Okay. So good afternoon, students.
I'll just introduce, ma'am. Fresh good afternoon to all of you. On behalf of Indian Medical College, I welcome all of you to this interesting session on anatomy. Today's topic is on infratemporal fossa, and we have a energetic and enthusiastic ma'am, Dr. Sharadha Ramanadham. She is a head and professor from Mount Zion Medical College, Kerala. Ma'am, good afternoon. We are happy to have you. You can start your session, ma'am. Thank you. Thank
you. Thank you, Balaji sir, for that introduction. It is very convenient for me to go ahead. So today we are going to learn a little bit about the infratemporal fossa. So infratemporal fossa, as the name says, it is below the temporal fossa. So temporal fossa is present in the lateral part of the head and neck region, and you're going to see that below that you're going to get the fossa. But this fossa is covered by the mandible. So the mandible is going to cover it, so you will not be able to see the fossa as such. So you've got to dissect it. Now it is going to be an irregularly shaped space, and it has got some boundaries. So we'll first look at the boundaries. What are the boundaries you're going to see? Now, when you see this lateral part of the skull, it is going to be covered by this small area will be covered by the zygomatic arch. So anything below that zygomatic arch, we call it as the infratemporal fossa. Now, it is going to have a roof above. It is going to be anteriorly related to the maxilla. Posteriorly, you can see that the styloid process is present. Of course, the tympanic part of the ear, the external auditory meatus, you can see. So these things are going to be a little complicated. The whole thing is covered by the lateral ramus, laterally by the ramus of the mandible. So how do you write it? So this is how you are going to write it. So anteriorly, it is by the posterior surface of the body of the maxilla. Now you can see the whole posterior surface of the maxilla. In the roof, it is going to be kind of pentagon shape, and it is going to be the greater wing of the sphenoid bone. Here you are going to see two foramina, one foramen ovale and one foramen spinosum. So two important structures will be passing through these foramina. So they are presenting in the roof themselves. Now next, medially, you're going to see the pterygoid plates. So you can see the yellow color. So that is the pterygoid plates. You have a medial pterygoid plate and a lateral pterygoid plate. You can see this small process down, and that process is going to be your the pterygoid hamulus. So yellow color, the small part, whatever is there. So that is going to be your hamulus. Now laterally, it is covered by the ramus of the mandible totally. Now what happens to the inferior wall? Inferiorly, it is open. That means it is directly going to be onto the floor of the mouth. So that's open. And even here also on the medial side, anteriorly, it is going to be covered by the pterygoid plates. But if you see the posterior part, it is going to be onto the pharynx. So it's also open, kind of. So whenever sort of infections are there, so you're going to have the problems here. They're going to spread. So what are the major structures that are going to be present in the infratemporal fossa? We saw some muscles of mastication. So we are going to have the medial and the lateral pterygoid muscles will be present. And you're going to have the nerve supplied to that. So the mandibular nerve is the one which is going to supply both the muscles. You are going to have the chorda tympani nerve that is going to come from the facial nerve. Of course, with the nerve to medial pterygoid, you're going to have a parasympathetic ganglion in this area. So that ganglion is called as otic. Near the ear, otic parasympathetic ganglion. The artery in this area is going to be the maxillary artery. Of course, it has got lots of branches, the maxillary artery. Then you're going to have, of course, the veins, the pterygoid venous plexus. Now, all of them are quite important with respect to the clinical implications. Coming to the muscles, one after the other one, we just start going and learning, seeing them. So this is the lateral pterygoid muscle. The whole fossa is going to be covered up or filled up by the lateral pterygoid muscle. So this lateral pterygoid muscle, you can see in the second picture. In the second picture, you can see two heads. So one is going to be the above upper head, and then you have a lower head. And I'm very sorry, I cannot do the annotation much because it's not taking up. Otherwise, you can see that the upper head is there. So you're going to have the upper head, and below you're going to have the lower head. This upper head, if you see, there is going to be a crest here. In the greater wing of the sphenoid, you're going to have a crest. And from that infratemporal crest part, you're going to get the upper head and, of course, the adjacent area. Then you're going to get the lower one. Lower one is going to be the medial pterygoid. So you're going to have the pterygoid plates here. So you saw the pterygoid plate. So this is the medial pterygoid, and the yellow one is going to be your lateral pterygoid. So that is the lateral surface of the lateral pterygoid plate. So come back, you're going to see the lateral plate, whatever is there. From there, the lateral surface, you get the lower head. So you got two heads. The upper head is smaller when compared to the lower head, and both of them will go behind and go to the joint, TM joint. As they proceed towards that, they're going to go to the capsule, and below the capsule, you are going to have a fovea. So that is called as pterygoid fovea. So this whole thing forms a small tendon and again gets attached here. Since it is attached to the capsule of the joint, it is going to bring about the depression action. So this is the one which is going to depress the mandible. So the other muscles which help in depression are going to be your mylohyoid as well as the anterior belly of the digastric. So these two are going to bring in the depression. So that's how the muscle works. Now we also have to do the medial pterygoid. So once you see the medial pterygoid, so that is the medial pterygoid muscle. So you can see that the muscle is a very strong muscle, and it is going to be inside. It is going to be present inside. From where does it come from? So you have this literature here. We're going to come back, but we're going to see in the picture how it is going to go. Now here onto the posterior surface of the maxilla, you're going to have the tuberosity. And from the tuberosity, you're going to get one head, and that is going to be superficial. So when we go back to this picture, you can see that that is the maxillary tuberosity. And this maxillary tuberosity is the one which is going to be giving the origin for the superficial head. And as the whole thing comes, it is also going to join another head, which is going to be from the pterygoid fossa. Now, where is this pterygoid fossa? It is between the lateral and the medial pterygoid plates. Between the lateral and the medial pterygoid plates, you have a fossa. You have a fossa. So it is going to get its origin from there. So the superficial head meets with the deeper head, and then it is going to form a single muscle, and then it is going to go to the mandible. And as it approaches the angle of the mandible from inside, it is going to be, it's a multipennate muscle, so it will go and attach to the angle of the mandible. Now we're going to see the theory part. How are you going to write it? Once you understand, it's quite easy to write it down. So the origin is from of the lateral pterygoid. So it is going to be, the upper head is going to come from the infratemporal surface of the greater wing of the sphenoid, and the lower head is going to come from the lateral surface of the lateral pterygoid plate. So it is inserted into the pterygoid fovea in front of the neck of the mandible. Of course, the capsule and the articular disc of the temporomandibular joint. This is very important because this is the one which actually brings in the action of depression of the mandible. Nerve supply, it is going to come from the mandibular nerve, of course. And you're going to have the depression. Relations are very important. We'll come to that. Now coming to the medial pterygoid. In this medial pterygoid, we are going to see how we are going to write out. So the origin is going to come from the tuberosity of the maxilla for the superficial head. For the deeper head, you're going to have it from the medial surface of the lateral pterygoid plate. So the lateral surface is taken up by the lateral pterygoid. So we are left with the medial pterygoid. So from the medial surface, you're going to get the medial pterygoid. And of course, the fossa and the other medial pterygoid plate, the lateral surface of it is going to take its origin. It is going to insert into the medial surface of the ramus of the angle of the mandible. It is from inside and it has got a triangle shape. So that is how it is inserted. Of course, the nerve supply is from the mandibular nerve. What does it do? It is going to elevate the mandible. If it is contracting, it is going to elevate the mandible, of course. And it is going to protrude the mandible. When both muscles are going to contract together, it is going to bring about the protrusion of the mandible. Now, we know that the medial pterygoid and lateral pterygoid will contract alternately. So, one medial pterygoid plus the lateral pterygoid on its side, on the same side. If they contract, it is going to deviate the chin. So, it is going to deviate the chin towards the opposite side. So, that is how it is going to bring about the chewing movements. So, that is going to bring about the chewing movements. Now, whatever structures you tell in the lateral pterygoid muscle is very much related to all these structures. So that is why we put under the heading as relations of the lateral pterygoid. Now, what are the muscles that is related? You have all the muscles of mastication. So some of them will be related superficially. So superficially, you're going to have the temporalis muscle. You're going to have the masseter. Of course, the ramus of the mandible, which you already have seen. Then you have the maxillary artery and the buccal nerve. Now, deeper to that, if you see, you're going to get the medial pterygoid, then the mandibular nerve, and you're going to get the middle meningeal artery with the otic ganglion. So the medial pterygoid, nerve to medial pterygoid will have the otic ganglion. Of course, the mandibular nerve is very closely related to the medial pterygoid nerve. You have some structures which will go above and down. So one which is going to come from its upper border are going to be the deep temporal and mesenteric nerves. So you have the deep temporal and mesenteric nerves. And below that, you're going to have the lower border. So the lower border, you're going to get the lingual inferior alveolar nerves with the maxillary artery. So these are the things we are going to see now. In between the two heads, you get the buccal nerve and the maxillary artery. So that is your maxillary artery, and it's so many branches, lots of branches you're having, is it not? So you have lots of them. Now go back to the lateral pterygoid muscle. Now that is the lateral pterygoid muscle. Now once the lateral pterygoid muscle is identified, we have to get to the structures. Now above this lateral pterygoid, you are going to get a muscle called as temporalis. So this temporalis muscle is represented in the first diagram. So in this first diagram, you can see that the temporalis is a huge muscle and it is going to come down and insert. When it comes down and inserts into the mandible, you're going to have the coronoid process. So it is going to insert into the coronoid process. So this whole muscle is superficial. So once this zygomatic arch is cut and the temporalis muscle is reflected, you are going to see the lateral pterygoid. So this is superficial. Now masseter also is quite superficial. So you're going to remove both of them. Then you're going to see the lateral pterygoid muscle. Once you see that, the upper margin you have identified. So from there, you are going to get the deep temporal blood vessels and nerve above that. Now coming to the lower border, you're going to get all the rest of the nerves. So you're going to get the inferior alveolar. That is very important. The inferior alveolar artery and the nerve. Of course, the lingual also will be down. So these two are very important below. From posterior side, you are going to get the chorda tympani. So that's one of the nerves which is quite important. Now, in between both the heads, you are going to get the maxillary artery. You get the maxillary vein also, but formation depends on its formation. If early formation, then you do get. Now coming to the neurovascular bundle, whatever the nerves and the vessels are there. Here the maxillary artery is given a little more prominence because of its branches. Now how to see these things? You will have to take out the lateral pterygoid muscle in piecemeal. So by piecemeal, by pieces, small pieces, you will have to take them out with the blunt forces, and you are actually destroying the whole muscle. So better see the muscle, then you take out, and then you will see this artery. Now, the maxillary artery is going to start from the lateral side. So that is going to be the terminal branch from the external carotid artery. And this will proceed medially. So as it proceeds medially from the ear, from the lateral side, it is going to go in between the two heads of the lateral pterygoid and goes to the spinopalatine foramen. So it has to go to the spinopalatine or pterygopalatine foramen. So that's its destination. So you can see that it is entering into the spinopalatine foramen. Now, divide it into three parts. The one which is to the mandible is called as a mandibular part. The one which is going to cross, that is in between, it is going to go, that is called as the pterygoid part. And the last one, which is going to enter after in the foramen, so that is going to be the pterygopalatine part. So these are the three, and these three parts will give the branches respective to the things which are very nearby. Now the first part, if you see, all of them have all five branches minimum. So you're going to get the first one. Now if you see the first one, this is the external carotid artery, superficial temporal, and then you are going to have this branches. First one is it is going to meet the ear. So once it meets the ear, it is going to give the deep auricular artery. This deep auricular artery is going to supply the external meatus, external acoustic meatus, and then it is going to go ahead. As it goes ahead, it is going to also give a small branch, that is your anterior tympanic. This anterior tympanic will be with the chorda tympani nerve. So you have the pterygomaxillary that fissure, and then you are going to go in between that. So you have that petromastoid part. So you have this tympanic, petrotympanic fissure and all that. So there it is going to enter along with the chorda tympani nerve. Now it goes inside, and it is going. It's actually tympanic, so it supplies the externally supplied by the deep auricular. Inner surface is supplied by the anterior tympanic and goes to the malleolar also. Then you're going to meet the third one, that is your middle meningeal. Now the middle meningeal, its destination is going to be the foramen spinosum. So it is going to go towards the foramen spinosum. Now, as it goes to the foramen spinosum, it is going to get two nerve roots, and these two nerve roots together join to form the auriculotemporal nerve. And so it is very next to the auriculotemporal nerve. The second one with the same name is accessory meningeal. So this middle meningeal has got a wide supply. It is going to supply the anterior and posterior part of the calvaria, the whole scalp, the calvaria, diploid, the bone as such, and the dura mater. Everything is supplied by the middle meningeal. That's why you get a real headache sometimes when it is the nervous spinosus is irritated. So that is the middle meningeal artery, and whatever is not supplied to certain extent is actually supplied by the accessory meningeal artery. So they are complementary to each other. Now below we are going to get one more artery, that is your inferior alveolar artery. This inferior alveolar artery is going to join its nerve, inferior alveolar nerve, nearer to the mandibular foramen. So as it reaches the mandible, it is going to go to the mandibular foramen. So this is the first part. So the first part. Now we'll try to identify the branches. So you can see this is the external carotid artery. From the external carotid artery, I'm going to get this nerve, the artery. So this is going to be the maxillary artery, and that is going to continue as a superficial temporal. Now that is my maxillary artery. So that is 2 M's are there. So that is where I am going to end my first part. So you have the deep auricular artery, which is going to the external acoustic meatus. You are going to have the anterior tympanic, which is going to be between the petrotympanic fissure. So that is where it is going to go along with the caudal tympani. And then you are going to have the first, the bigger one, that is your middle meningeal. And then you are going to have the accessory meningeal. And then down, you are going to have the internal, that is going to enter into the mandibular foramen. So that is your inferior alveolar. So it's kind of deep, goes in. These are kind of superficial from lateral side, and that's that's one of the deepest branches. Now, next you are going to go to the second part. So the second part is going to be from there to there. So it is going to be in between the two heads of the lateral pterygoid. And we are going to have all the muscles. You have the muscles of mastication. They are all supplied by this part of the artery because it is coursing through them. So naturally it will supply the muscles. So what are the muscles you are going to have? You have the temporal. So to the temporal, two deep temporal arteries it is going to give. They groove the bone and then go that to the fossa. Then you have the pterygoid artery. So the lateral pterygoid gets it within themselves, and of course the medial pterygoid also. You have the mesenteric artery, which is going to, you have this mandibular notch. So it is going to come through the mandibular notch and supplies the masseter from inside to out. It is going to come. Last one is the buccal artery, and that buccal artery is going to supply the cheek. The whole cheek, whatever you have a blood supply. So that is going to come from the buccal artery. Now I'm going to identify a little bit. So you can see the buccal artery. So that is the buccal artery, and the whole cheek it is going to supply. That's its destination. Now next is we are going to look for the last one. The last one is it is going to go into the pterygopalatine fossa. First it forms a foramen and then enters into the pterygopalatine fossa. So hardly a small area is available. So what does it do is it is going to supply, you have this posterior superior alveolar branches. These are posterior to the superior alveolar. So it is a 2 or 3 number actually. Then after that, it is going to course ahead. As it courses ahead, it is going to, the last part is going to be the maxillary nerve it comes nearer to that. So the maxillary nerve actually is going to enter into the infraorbital foramen. So as it comes to the infraorbital canal, it is going to get a artery. So infraorbital artery, that is a bigger one. After that, you are going to get the smaller branches. The smaller branches are, there are so many foramina there. Nerve to the pterygoid canal is one important thing. Then you have this omerovaginal 2 or 3 small canals. So it is going to go into that. The last part, that is the spinopalatine artery, whatever it remains as. So that is a big one because it has to supply the spinopalatine whole fossa as such. It supplies. So that remains as a bigger chunk. And it also supplies, anastomosis with the facial artery, the septal branch. So main problem for bleeding, epistaxis. So that's what its clinical importance is. Now, apart from this, you're going to get the palatine arteries. So what are the palatine arteries? You're going to get the greater palatine artery and the lesser palatine artery. So 2 palatine arteries are going to be there. Importance, not much. Now, once we know the artery, we have to know the venous supply. So the whole muscle as such, if you see, it is going to be the pterygoid muscle. And this pterygoid muscle is going to have a lot of venous plexus inside it. So the blood supply is going to go either way. Wherever the pressure is more, it is going to go. So that's the main problem of this venous plexus, and it is also going to communicate. Now, all these things are going to communicate with each other, and then it is going to form a single vein that is going to be a maxillary vein. And as it comes to nearer to the parotid gland, this maxillary vein is going to form the retromandibular vein along with the superficial temporal vein. So that's how it is going to end. Now onto the medial side, onto the sagittal side. So what happens is onto the facial side, all these things are going to form a vein. So that vein is called as a small common facial vein. Okay, so that is going to join with the facial vein proper. Now, as it is going towards the orbit, so there also small twigs are there, and they combine and they are going to go to the inferior ophthalmic and all those veins, superior ophthalmic veins, and that actually communicates with the cavernous sinus. Now, that's the problem. So, whenever you have infection in the nose, that is the little area in the nose as well as upper lip, if there is any septic embolus, septic thrombus, and that is going to become embolus. That is going to go to the cavernous sinus. And once it goes to the cavernous sinus, it will lodge in the cavernous sinus. And that is going to bring about the cavernous sinus thrombosis. And of course, the syndrome. So whatever I said, the whole thing can be written down. So this is how you are going to write up, you know, the anastomosis of the pterygoid venous plexus with the facial vein and the cavernous sinus. It is going to be represented, and it is going to form the facial vein, and then it is going to have no valves, and then it is going to form the cavernous sinus. The next is mandibular nerve. Now, mandibular nerve is going to come from the trigeminal ganglion, and it is going to be the middle cranial fossa. After that, it is going to see that is the semi-lunar of the Gasserian ganglion. So it is going to come out from there, and that is going to be your mandibular. Now, as it comes out, it is going to meet a small, you know, adjacently a small root will come and join it, and together they are going to go into the foramen ovale. And as they enter into the foramen ovale, they're going to join together to form the mandibular nerve. And once they form the mandibular nerve, immediately it gives a small nerve, and that is going to go reverse. And that is the one which is going to supply the middle cranial fossa nerve supply. The whole dura mater is supplied. Now, as it comes down, it is going to go one branch. It is going to give medially. So, as it gives this medial branch, it is going to be the nerve to medial pterygoid, and it is going to have the otic ganglion. So, the nerve to medial pterygoid is the one which is going to have the otic ganglion. After that, it is going to come down. So you can see that. So it is going to be divided into two. It is going to be the anterior and the posterior branches. Now, if you see the anterior branches, all of them supply the muscles. They are all supplying the muscles. So you're going to have the mesenteric branch, you have the deep temporal branches. These go to the temporalis and lateral directly. It goes into the muscle. Then you have one sensory, that is your buccal nerve. So this buccal nerve is a sensory branch. Area of supply is the whole area on the cheek, but usually from the inside. That is what it supplies the mucous membrane. That's what is main importance of this buccal nerve. And then you're going to go to the posterior branches. Now the posterior branches, if you see, you're going to have the auricular temporal nerve, you're going to have the lingual nerve, and the inferior alveolar. So these are the posterior branches. If you see all these branches, they are very important. Actually, it's the posterior branches which are more clinically we see the problems. So if you see the auricular temporal nerve, this nerve comes out by small rootlets, and then it is going to form two big rootlets, and then it is going to wind or go around the middle meningeal artery. As it curves around the middle meningeal artery, it is going to become single, and then it is already into the superficial temporal arteries and you know, the vein, the vessels. So it will go below that, and then it is already reached its destination, and it is going to supply a wide area just above the ear. So the whole sensory, it is a sensory. But this also is going to be associated with the otic ganglion. So that is why it is going to carry the secretomotor fibers to the parotid gland. Lingual nerve, most of the people know that lingual nerve is going to be the nerve which is going to be of general sensation to the anterior two-thirds of the tongue. Now what happens is, as it is coming down, it is going to get one more nerve, and that is your chorda tympani at right angles. And this chorda tympani is the one which is going to get the taste sensation. So the fungiform papilla, whatever are present, they are going to get the taste sensation. So that is the lingual nerve. And then the last one is inferior alveolar. So if you take the inferior alveolar, it just comes down and it is going to go to the mandibular foramen. As it goes to the mandibular foramen, it is going to enter, giving out the mylohyoid nerve. And of course, the artery also joins, and they are going to supply everything, the lower jaw, the sockets, then the teeth, and then it is going to supply the floor of the mouth, and then it is going to be out as the mental. So this is all the theory, how you write up the theory, and this is for the auriculotemporal nerve. I need some time for the OT ganglion, wherein I can complete the auriculotemporal nerve. So how do you identify these nerves when you start in the dissection specimens and all? Look for the submandibular ganglion. Wherever the submandibular ganglion is there, that is going to be the lingual nerve. And lingual nerve will go medially towards the midline. Whereas if you take the inferior alveolar, it is going to come away from the midline. So it is destination is mandibular foramen. So you can follow up till that. The problem is both of them are very next to each other at the third molar. So when you take the third molar and just go a little below the crown, you will still be with the lingual. And anteriorly, around 2 centimeters anterior at this point, you are going to get the inferior alveolar. So the posterior, it is posterior because it is to receive the chorda tympani. After that, it is going to come anteriorly and medially. It curves and comes forwards. So at that is where you give the blocks. You give the inferior alveolar block and the lingual block. So when you go posteriorly, you're going to actually block the lingual nerve at the third molar. And if you come anteriorly, you're going to block the inferior alveolar. So this is the trick. So you can see the lingual nerve with the ganglion. So you can just try this. And if it's a good specimen, you can see the chorda tympani also being turned up. And that's the foramen, we've been the petrotympanic fissure. You get that. The whole thing is the squamotympanic, all these things come. So that is the chorda tympani nerve. You can make out that it is going to join the lingual. The lingual it is going to join. So you can see the chorda tympani. So I told about the blocks, and this is the write-up of the blocks. So whatever is there, you're going to write it up. Now coming to the last portion, that is your otic ganglion. Now otic ganglion comes under different headings, is it not? So what happens is, first you have to tell where it is present. So it is around 2 to 3 mm in size, and that is around the oval shaped and brown in color, and it is going to be present just below the foramen oval in the infratemporal fossa, and it is very next to the origin of the medial pterygoid nerve. So nerve to medial pterygoid. Now what happens is, as it comes down, this nerve is very topographically next to the mandibular nerve, as we saw. But then if you see its connections, it is not like that. It gets its fibers from the glossopharyngeal. So it is going to be ninth nerve, which is going to give the fibers. Now, if you take any ganglion, it is going to have a parasympathetic, it is going to have a sympathetic root, and it is going to be having here, you're going to have the motor roots which pass through and through. So the parasympathetic, if you see, the presynaptic ones, they are going to come from the glossopharyngeal, and this glossopharyngeal, they're going to get the tympanic branch. that tympanic branch is going to communicate with the lesser petrosal nerve. This lesser petrosal nerve is going to come down, and that is the one which is going to go in connect with the auriculotemporal. And that auriculotemporal nerve is going to go to the parotid gland. So that is how the secretomotor fibers will reach the parotid gland. That is very important in the the parasympathetic ganglia. Now coming to the sympathetic, it's very easy. You know that it is going to be the middle meningeal artery that is going to be very near to the parotid gland. So you're going to get it from the external carotid artery, then the maxillary, then middle meningeal. Now from where the sympathetic fibers come, they are going to come from the superior cervical ganglia. So the superior cervical ganglion is going to give the branch. So till T1 to T5, it is going to have the branches. So it is going to be the upper 5. So it is going to get the branches from there. And then it is going to go to its destination. What is its function? Vasodilatation. Now coming to the medial pterygoid nerve, it is going to go to the muscle. Okay, fine. But then what happens to the other two small ones? So you have the tensor tympani and the tensor veli palatinic. They also will be supplied by the nerve to medial pterygoid, and they are not going to relay anywhere. See them straight, they go to the muscles. Now, apart from all these things, you have lots of, you have this nasopharyngeal tumors, you have all these things which can be operated. So that procedure is going to go through the infratemporal region. So you have a transoral, transantral, transpalatal, maxillary, then you have so many otomies and all that. This maxillary swing is one big procedure that is being followed for the usually the tumors, especially what are present in the nasopharynx. This is the this gives a good approach and a clear cut. Nice surgery can be done. So that is the clinical importance of this. So you have all these approaches present, transpalatal approach, and you have this maxillary approach. So you have to do the osteotomy. That is the main problem. Only the swing is the one which is going to be giving you a slight amount of maxillary cut, and then you get a good view. So that's why it is followed. So I am almost up on the time. So any questions, you please type it in the chat, or you can start asking the questions. This is in just about the infratemporal fossa. So thank you for listening till now. Sir Balaji sir, I have completed the topic. So any questions, please? You can type on the chat also.
Ma'am, finished, ma'am?
Sir.
Okay. Thank you, ma'am. Thank you. So we will wait for another 2-3 minutes, ma'am. If students have any doubts, I will ask you, ma'am. But mostly the viewing is this will be archived, ma'am. So it will be there in the library YouTube channel. So slowly they start viewing it. So we will just wait for another 2 minutes.
Sir. And any questions, they can approach me. No problem.
Okay.
Anytime.
Okay. And meanwhile, we have another 2 more interesting sessions at 5 o'clock. Pharmacology topic on estrogens and anti-estrogens by Dr. Meena Dev. And 6:30 we have another interesting topic from psychiatry on alcohol abuse. So stay tuned to all those topics. And tomorrow also we have interesting sessions. Everything is posted in Facebook. The schedule is available in Facebook. Tomorrow also we have 3 sessions, so stay tuned to watch them. uh, Ma'am, I think there are no questions. So I thank you, ma'am. Thank you very much. It was a wonderful session. I think almost all slides you had pictures to demonstrate them. So I think
Yeah.
you said it's a tough topic also. So they will definitely make use of it. Maybe when exams come, they will come back and they will surely go through it. So it's easier to watch a 45 minutes rather than reading for hours together. So I think they will definitely benefit. And I thank you once again, ma'am, for sparing your valuable time. Thank you very much, ma'am. Thank you.
Thank you, sir. Thank you.